panel members, as well as we are extremely happy to have with Dr. Asim Kumar Samar, who is the senior medical oncology from Mahavir Cancer, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. So he is the senior medical oncologist, consultant medical oncology from our medical oncology department. Along with we have around 6 to 7 panel members. So instead of spending other time, so I request Ms. Anjana, who is from our medical team, to introduce the other panel members, as well as to start the sessions with the a small brief of the agenda. Thank you.
Okay. Thank you so much, Saurav. Again, good evening, everyone. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana Yadav from the medical team of Samarth Life Sciences. On behalf of the organization, I am delighted to welcome you all for today's webinar that we refer to as OSMOSIS. This is a scientific initiative by our oncology division, OnQuest. In this activity, Samarth as an organization aims to provide a scientific platform to discuss on various topics which are related to oncology specialty. We therefore believe that osmosis is just not a scientific platform but also a powerful metaphor for knowledge dissemination. Now, this process of knowledge updation is very crucial, especially in the ever evolving field of oncology, where continuous learning and adaptations are essential for improving the patient outcome. Today's program is also a testament to our collective commitment to at staying at the forefront of medical advancements and providing the best possible care to our patients. The focus point of our discussion today will be on a masterclass on prostate cancer. We are fortunate to have with us esteemed experts who will share their insights and experiences on this topic. Before we start, let me give you a brief about our company profile. Samarth Life Sciences. Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. With its inception in the year 1963 by Mr. Gunwant Lal Shah, Samarth Life Sciences has been a prominent player in the pharmaceutical industry. Samarth Life Sciences operates through 14 therapeutic specialty divisions, each focusing on specific areas of healthcare to provide the targeted solution and expertise across a broad spectrum of medical conditions. OnQuest is one of the divisions that caters to the oncology specialty. Samarth Life Sciences is a WHO GMP and ISO 9001 certified that ensures the highest standards of quality and manufacturing practices. We export over 250 products in over 70 countries, demonstrating our global presence and commitment to serve the diverse market. We are also proud to share that Samarth Life Sciences has received significant accolades and recognition, reflecting its excellence and influence in the healthcare sector. With this short brief about us, we would like to initiate the scientific program. For this, I would like to introduce our program director for today's session, Dr. Asim Kumar. Dr. Asim Kumar is a senior consultant at Department of Medical Oncology, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. He'll be taking us through a case presentation on prostate cancer. Let us have a look at the panelists for the case presentation. So the panelists today with us are Dr. Surendra Beniwal, Senior Consultant, Medical Oncology, Acharya Tulsi Region Cancer Treatment and Research Institute, Bikaner. Dr. Umesh Khandelwal, Senior Consultant, Medical Oncology, Cancer Hospital, Jaipur. Dr. Prashant Kumbach, Senior Consultant, Medical Oncology, Narayana, Multi-Speciality Hospital, Jaipur. Dr. Ananya Parekh, Consultant, Medical Oncology, RHL Renova Cancer Center, Jaipur. Next, please. Dr. Anu Rajput, Consultant Medical Oncology, Medipulse Hospital, Jodhpur. Dr. Mukesh Kumar Jhandu, Consultant Medical Oncology, American Oncology Institute, Hisar. Dr. Neha Rawat, Consultant Medical Oncology, Santokba Durlabji Memorial Hospital, Jaipur. Next, please.
So with that, we request Dr. Asim sir, please take on stage and you can start your presentations on the hormone sensitive prostate cancer, the case studies.
Over to you, sir.
Thank you. Thank you, Team Samarth. And now I will share my slides. So, would you please stop sharing?
Yeah. So you can share now.
Okay. So you must be seeing our slides, huh?
Yes, sir.
Okay. So first, I would like to just pay my gratitude to our senior colleagues who have joined. Dr. Surendra Beniwal. Sir, join. Dr. Surendra Beniwal, my colleague Dr. Umesh Khandelwal, Dr. Prashant Kumbas is from Jaipur, Dr. Ananya Parekh, Dr. Anuraj Purohit, and Dr. Neha Rawat and Dr. Mukesh. So we'll run through the few slides which is in the presentation form and we will discuss informal. So this is the castration resistant prostate cancer. We all know. Just a minute. Huh? Okay. So first, it's a very basic thing. Castration sensitive prostate cancer.
Sir,
Yeah,
requesting
hello.
you to please share the screen. We could see the icons. Can you please full screen?
It's already full screen, I guess.
So it is just at the bottom of the slide, your laptop or system, slide share.
Oh, I'm sharing that. Now it is okay.
Yes,
Yeah,
sir.
yeah.
Yes, sir.
Okay, fine. So it was a castration sensitive prostate cancer, and the thing is how we treat it today. So we all know the mechanism of action of how the prostate cancer is related with the testosterone levels. So sometimes we find the prostate cancer patient they are de novo, and mostly actually 75% of the patient of the prostate cancer are de novo, and sometimes they are found to be having locally advanced disease. Very few patient, but we do nowadays we have patient who are diagnosed out of the some screening program, but until proved otherwise, they are in generally in locally advanced or metastatic cancer stage disease. And if you see uh, locally advanced prostate cancer, we give some definitive therapy, and there is a after some period of time, maybe in the months or maybe in the years, there may be again rising of the PSA level, and biochemical recurrence we know BCR is there, and it might land up into the metastatic prostate cancer, and sometimes they are non-metastatic castration sensitive prostate cancer. So this is the very rare variety which we see in the bottom level, but ultimately by any pathway they are culminating into the metastatic castration resistant prostate cancer. And this is the final verdict of the all prostate cancer patient. They turn up before they conclude their life. So what is the hormone sensitive prostate cancer? Defined as a disease that has either not been treated with or is still responsive to ADT. So we'll start panel discussion. This is not in the case form, but it is in the general practice form. So I would like to start with our dear colleague, Dr. Surendra Beniwal. So, boss, we all know like prostate cancer is a disease of the elderly age group population, and generally they present with the some ton of side effect like back pain or some LUTS, and now you start doing the workup. So my question to you is, nowadays in the era of 2025, in the first go, which type of the test you want to do? So anyone, sir? Hello.
You can take the questions to others. I think there because of the network issue he has left. He's joining shortly again.
No problem. So Dr. Umesh is there?
Yes,
Hello,
boss.
Dr.
Yeah.
Umesh.
Yes,
Yeah.
yes.
Dr. Umesh. Now I can see you also. Screen sharing has stopped as the shared window is closed. Okay. So Umesh, my question is, nowadays in 2025, if you want to do a workup of the prostate cancer patient, which type of the test you involve if patient has no problem with the funds?
Boss, I would like to go for first. We have done PSA. After PSA, we'll go for prostate biopsy and then directly PSMA PET scan. Definitely,
Okay.
these are the basic tests. And after the if patient is having localized disease, the approach will be depending on the life expectancy, the surveillance, or maybe the curative treatment. And if it is metastatic, which we see most of the patient have bone metastasis, then palliative treatment along with the genetic.
Definitely. Actually, I was very unfair because I need to give some scenario to discuss with. So suppose patient is 77-year-old male
Yes.
with no comorbidities, and now he is presented with the LUTS symptoms. One scan outside, which is not PSMA PET, is showing some densities in the bone.
Okay.
And now some urologist has referred to you. So what will be your purview to see that patient?
So first, the PSA is done. PSA.
Yeah,
PSA will be
PSA, but
done.
all the time we find like it's not from the reliable lab. So PSA is maybe like 35.
35. Okay, and then if there is bone mets in the one of the scan, as you say that we will
Suspected.
suspected bone mets definitely. So we'll go for prostate biopsy definitely after digital rectal examination. If or will I prefer transrectal ultrasound, and if there is suspicion of malignancy, then true cut biopsy, transrectal ultrasound guided biopsy, and then further planning after the biopsy. If it is adenocarcinoma, then definitely if suspected bone mets, then also I would like to go for PSMA PETs.
Exactly, correct. So, Dr. Anu, would you
Yes.
differ in the opinion, or you may have some other test also to in your is
So,
the battery of the test?
okay, good evening all. So in that outside scans, only bone mets were there. Prostate is also
Hey,
showing
they
some
said like
mass
it's some heterogeneous densities are there in the bones.
bones, and okay, prostate is not mentioned.
Prostate is enlarged.
Last, okay. So dedicated scan, like including MRA, dedicated prostate specific, and then PSA already we have done. So we'll go for the biopsy later. Based on the biopsy report, we'll get PSMA PET also.
Right. Okay. So, Dr. Ananya, my question is to you. How often you do PSMA PET? Suppose you need to see 10 patient in a month, new patients. So, and this is the all scenario is 75 plus and back pain and all that. So, how often you do the PSMA PET?
Sir, one or two patients, because sometimes in practical scenarios the financial issues are there, but still we advise to go for the PSMA PET CT. One or two patients definitely, sir, and out of 10.
Okay. So, you are doing bone scans then?
Sir, we are doing PET CT if bone metastases are already there, and if the patient is affordable for lutetium therapy, or we have already given multiple lines of therapy, then definitely, or if there's some doubt in the bone metastasis, because sometimes in MRI or PET CT they give degenerative changes, then definitely, sir, I advise PSMA PET CT.
Actually, nowadays, suppose patient land up in our OPD, so we prefer to do PSMA PET, even if they are from the non-paying category or from the Vamash or BPL, whatever. BPL to not, but otherwise, in almost every patient, we try to push them hard.
Yes,
Why?
sir.
Because
We also try, but the
it-
thing is, this the difference amount is more than 10,000. So not every patient does like go for that scan.
no, but we
We
make
try,
them
sir,
greedy.
definitely, sir.
We try to drive and we make them greedy, like you do this test, and then your treatment will be free under the schemes. So if you don't
Definitely,
do,
sir. It should be
then
advised to every patient.
yeah, actually.
Yes.
So a PSI PET is the need of the hour, I guess, and most of the time, even MRI is confusing because some degenerative changes in the pelvis in the rural population is very common. So they say like some densities are looking at the SI joint and all that. So they're very much confusing. So commonly we do send the patient for PSMA PET. I said like PSA is 35, but we often we repeat the PSA level and it is something like 100 and more than 100. So but it is again a thing is we do check the PSA level in our lab so that we can compare in the future also. Otherwise, sometimes they have the 5 or 10 reports of the PSA of the multiple time points, and sometimes they are high, sometimes they are low. They have taken some treatment by biculotamide outside, and there is scenario is very confusing. So we do baseline PSA level. We send the patient for you can say what PSMA PET, and almost it is if it is 35 or 100 or something PSA level, they are very sure they have the prostate cancer. So we take the appointment for PSMA PET, and then we try to prepare the patient for the biopsy. So suppose patient is 77-year-old in front of you. So which kind of the
Sir,
comorbidity you are looking at?
can you please share your screen? Or
No, I am not sharing. Actually, we are discussing. We are
actually
not
it
going
is
by the things. Na? It
okay.
is
Okay, no problem.
okay.
It's
So
so
my question is, the patient is in front of the Dr. Ananya, and uh, she wants to send the patient to the intervention radiologist. So which kind of the things you will look at? In general, we are all looking at.
Yes, sir. We want to see, sir. We want to take trust-guided biopsy, and minimum 10 cores should be taken, sir, for the complete grade grouping for the prostate cancer, sir.
Yeah, 10 to 12 course they are
Yes, sir.
taking.
Yes, sir.
But we had 1 or 2 incidences where the patient had gross bleeding. After that, we are very alert, and we used to ask them, are you on some thrombolytic therapy or whatever
Yes, sir.
antiplatelet therapy?
Yes, sir.
So sometimes they hide also, they don't know, and some even if they don't have any cardiac event in the rural population in GPs, they start echosprin.
Yes, sir.
So very important to check their medication if they have with them, and if anything is there, then you give the gap of 5 to 7 days
5 days, sir. Yes.
because sometimes the bleeding starts and it will not be recover, and there will be unpleasant scenarios. So we definitely ask the patient for
Yes, sir.
uh,
We check for
showing
that.
us the medication even if they are not giving the history, and we are sure like if they are not on antiplatelet drug, still we do the PTNR and then send the patient for the
Definitely.
trust guided biopsy. So that is fine. They are going for the trust guided biopsy. So now I will leave Ananya and ask Dr. Mukesh Andu. Dr. Mukesh is our dear and favorite colleague from Hisar.
Very good evening, sir.
Mukesh, can you see you? Yeah, thank you. So your certificates are looking very good. So Mukesh, the patient is went for the biopsy, and they have asked you like, sir,
Please
we
speak
should.
loud, sir, little.
Okay, I will check my voice. Okay. So after that, we have done the biopsy. How you will proceed for?
After biopsy, how I will proceed?
Yes, yes. In the 77-year-old male.
Yes, sir. I will look in PSMA PET scan whether it is metastatic or not. If it is not metastatic and confined to prostate, then depend upon the risk category, I will proceed. If it is metastatic, then I will say burden of disease, either heavy or low burden of disease, depend upon the visual metastasis or not. And if it is confined to bone, then number of bone metastasis, if it is more than four and one outside the pelvis, or then I will see that whether it is low or high volume burden of disease. Depend upon that, I will proceed.
Exactly.
How to proceed.
So, but today we had a very different kind of the scenario. I had a surgeon who was 77-year-old male, and he had done the PSMA PET from our institute, but as a non-registered patient. So he came with the report and said, like, sir, this is my report, and you look at, I am metastatic or not. So I was so surprised because the surgeon was asking. So what happened is there was some uptake in the prostate. One or two iliac nodes were there, and there was some nodular uptake either in the spermatic cord or maybe some nodal area in the vicinity of the spermatic cord. So how to define that? So I explained that patient like it may be in the spermatic cord, but nodular uptake is very rare. There might be some nodule which is overlying over the this spermatic cord in one side. So whatever be the reason or whatever stage you consider, whether it is stage 4 or not, but it is a curable disease because it will come into the field of the RT, right? And it is not a very much you can say the horrible disease. So you don't worry about that. If it is in the adjacent organ, then it is what T3B, right? So making them assured is very difficult, but sometimes we find this kind of the situation also. It is looking like inguinal node or maybe spermatic cord, nodular uptake, or maybe some vessel is kinking over there. So this was the scenario. So anyways, we started treatment with the curative intent. So my question to Dr. Dr. Neha Rawat, has she joined? Okay, Dr. Prashant.
Yes, sir.
I
Hello.
put Prashant our screen. Hello, Dr.
Hello.
Prashant.
Hi,
We
sir.
never met on the webinars. So good to see you.
Yeah.
Yeah. So Prashant, my question is, suppose this patient is oligometastatic or non-metastatic, right?
Yeah.
Which we were discussing, 77-year-old male with PSA 35 and intrapelvic node with spermatic cord uptake, which we are considering as a adjacent organ uptake and not metastatic or oligometastatic. So my question to you is, he is very learned because he is a surgeon himself. So how you would counsel about the definitive treatment?
So definitely I will, as the disease is at adjacent organs, so definitely I will advise for curative intent treatment. And before treatment, we'll do all comorbidities workup, like whether patient has diabetes, hypertension, ECG, echo, and viral markers, all these we'll do. And we'll plan for curative intent radiotherapy with androgen deprivation therapy.
Okay, so we were driving this patient in the same way, but suddenly he said like my younger colleague or younger brother is in the USA, and he's also a doctor, and maybe he was a urologist, so he wanted to speak to me about this one. Then I instantly I framed the my statements like you can go for the curative intent radiotherapy also, and maybe with the robotic surgery also, because I need to counsel the USA situated person.
Yeah.
So he was asking ki, what is the advantage of the surgery and what are the demerits of the surgery, and in this form, like in the balancing form, you need to I need to spoke to them. So my question is to you is, what are the merits and demerits of the surgery if patient is affordable for the robotic surgery and he wanted to go to Gangaram and all that?
So, as the patient's age is high and patient have some comorbidities,
Exactly. Yes, yes.
so definitely robotic surgery is not possible. And even if we do robotic surgery, though, then the chances of positive margins may be high. So if we get a positive margin, then the post-op radiation will be there.
One is good
So,
point you have made. Yes,
so
yes.
if we go for robotic surgery, will give all the complications of surgery, followed by if there is a need of radiation, which is very imminent in this case. So the side effects of surgery as well as the side effects of the radiotherapy.
Exactly. So the thing is, he wanted to ask me like, if I go for the robotic surgery, and some daily surgeon was counseling him like, nowadays with the robotic surgery there are very less side effects, and even if the side effects are there, they will be resolved in 6 months or maybe in 8 months. So whether I should go or not. So I just frankly said like, sir, you can go for robotic surgery, but one is the embarrassing side effect is the dribbling of the urine,
Yeah,
which whether they accept it or not, it will be there
yeah,
in the 99% of the cases. And the other thing is, uh, this is the demerit, but the surgery has a advantage. Like if you go for the surgery and patient relapse after suppose 1 or 2 years, then again you can offer the radiation.
yeah,
And simultaneously I needed to counsel the patient, if you go for RT, there may not be the side effect of this kind of urinary dribbling, but there may be radiation proctitis.
yeah.
So
Radiation
incidences are
proctitis.
rare or low, but you may have. But initial period of the time, you may have very pleasant life because of the uh, less social embarrassment.
Yes.
So he wanted to decide upon. In within 2 hours, he came to me and said like, sir, I want to go for RT. So now you tell me what is the demerit of the RT. One was the radiation proctitis, but other was, surgeon says, if you give the RT to the prostate, then the surrounding tissue is very hard, and if patient recur or there is a biochemical recurrence, then surgery will be tough.
Yeah,
So in one go you will lose the two options. So I said like, it may be the case, but nowadays other therapies are available, so you don't worry about that, and the results are equally good. So finally he
yeah,
went for the hormone therapy. So Dr. Anu,
Yes, sir.
Prashant, I will move to the Dr. Anu. So suppose patient opted for the uh, hormone therapy because he
Okay.
was high volume, high risk disease, and
Okay.
then he wanted to go for the radiation.
Radiation.
Which type of the now hormone therapy you want to use, ADT?
Okay. So we can use, like, I want to use medical ADT, of course, and I will explain all the benefits of giving medical ADT. In medical ADT also, whether to give antagonist or agonist, depending on the patient's comorbidity, especially cardiovascular health. And usually in metastatic, we choose by the urgency and the need of the response, the urgent response, by giving the antagonist. Suppose if quad compression is there or we need quick fixation, quick response, then yes, I prefer antagonist. But in this situation, both can be given. But given the comorbidity risk, I will prefer antagonist over agonist. If no risk, then both can be preferred. Yes.
Exactly. So patient was learned, so he wanted no flare reaction and all that. So we also advise the same thing, antagonist. We started that also.
Okay.
But again the patient asked the 10 questions. If they are learned and they are from the same field.
Yes.
So they ask us like, what are the side effect of the Degarelix, which I need to worry about, and what are the side effect of the which you are suggesting 3 monthly therapy or maybe the oral thing.
Yes, sir.
So any shortcoming of the Degarelix which you want to explain them.
So we need to monitor all the, like, status of the bone health, osteoporosis is already there or not. So because eventually it will develop, we need to monitor that also.
Yeah. So I frankly said like, there is no worrisome side effect. You go for it, and if anything happens to you, we will take care of that. Don't worry about that.
Yeah.
So in 1 month there is no bone resorption or nothing will happen. So, do you advise your patient in your clinical practice? It is not like book-like thing for the orchidectomy nowadays.
I usually don't, but if patient is willing for orchidectomy over getting injection again and again, whether monthly or 3 monthly, then yes, you can go for orchidectomy.
Actually, we generally refer and we drive the patient in such a way like why to go for the orchidectomy if
Yes.
equally good options are available.
Yes.
And even if you go for orchidectomy, you need to come as for follow-up for 3 months.
Yeah,
What is harm in getting one IM or subcutaneous injection? So generally they agree upon,
I agree.
unless they are in the hands of family surgeons and all that.
Hmm.
Otherwise they agreed upon.
Most of them choose medically.
Yeah, the problem with the surgical orchidectomy is uh, psychological side effect. Because
Mhm.
they see every time they have the bath and they see the empty scrotum is
Yes.
a little bit distressing. And the other thing, even if you see you fix the prosthesis, still
Mhm.
they will have the feeling. So we
Yes.
counsel them generally to go for the ADTs and all that. Right.
Yes.
So actually they asked me to do for 35 minutes, but still we can go further for 5 minutes. So I will just cutting the things and all that. But you tell us, Dr. Anu,
Yes, sir.
nowadays anything which you are doing, opting the what you call is biomarker testing policy in your clinical practice in the CRPC setting, not in
Okay. So in
this setting
CRPC,
because
yes, we
it is
need
the
to do
new
it.
thing which
But because these days everybody is saying, ki, let's do it in the upfront, like when
front
patient
setting.
is, yes, yes. So that time only you get it done so that later it will be convenient. And you can also prognosticate the patient. And some data is also there ki in hormone sensitive, you can combine PARP inhibitor with the abiraterone.
Data,
So that
data
data is also there.
upcoming. And
Yeah.
basic problem by doing in upfront in first stage is archival tissue after 2 or 3 years.
Yes, yes,
In
sir.
no tissue, patient will not allow you to do the repeat biopsy. This is the
Yes, sir.
basic thing which we can do. So we
Yes.
have started counseling the patient for to go for the molecular testing or BRCA testing and all that. Yes.
Yes.
Okay. So Dr. Prashant, I would move one question to each in very short period of time. So Dr. Prashant,
Yes.
suppose in CRPC setting you got like patient is BRCA2 positive
Yeah.
and he has been exposed to initial docetaxel in metastatic setting and
Yeah.
Eritron also. So how you will modify your now it is you want to give third line and patient is in general good condition and there is no further deterioration of PS but patient has biochemical relapse and it will be symptomatic increment in the bone pain.
So patient has taken all hormone therapy as well as patient has taken docetaxel, even cabazitaxel.
No, patient has taken docetaxel and this one ADT and Abiraterone.
Aberrant, no enzalutamide, and
No.
so we can combine this enzalutamide with some PARP inhibitor, or if affordability is issue, then we can go for cabazitaxel.
In what dose?
20
Generally
milligram per
in what 20 milligram you give?
yeah.
Okay, yeah. We have stepped down to 15 mg per meter
Yeah,
square.
depending on the
Yeah, in the lines of further lines you want to use. And Dr. Ananya, I will move to you. What is the status of lutetium therapy in your practice?
Sir,
Lutetium,
once patient has received docetaxel and abiraterone, sometimes I like if patient is BRCA positive, then between the two hormonal therapies, I would like to either because he has already received docetaxel, so I would like to give single agent PARP inhibitor as of now. Because sir, in eventually we have to use multiple lines of therapies. So I would like to introduce PARP inhibitor with bone modifying agent and SOS palliative RT. And then we can think about, sir, in the later lines about enzalutamide and cabazitaxel and Honvan and every other drug.
but all this one nuclear medicine trial they have shown the lutetium therapies results they are best if you use in the earlier line. So they are
Okay.
after our life like you why don't you use in the earlier lines
Yes, sir,
where patient's
definitely.
marrow
We
is
can, we
fired
can,
and then you want to use. So
yes, sir.
very difficult to manage. Yes, but we have not opted this policy. So we as you are giving, we are also giving multiple lines of the therapy and all that.
At
And
last, we keep lutetium therapy when every other option has
it
exhausted.
has a
I
valid
think we
reason
should
also.
incorporate it earlier.
It has a valid reason also. Why? Because a patient is elderly in the age group and their marrow is, we don't know the status of the marrow fibrosis and all that. And if you use lutetium and they are dependent on the transfusion, then your life will be hell. Because every third, fourth day they come with the blood transfusion or platelet transfusion. Then we did 3-4 years back or 5 years back, 1 or 2 patient. Then till they died, we were not free from that patient. Nuclear medicine doctors, they don't admit the patient
Yes,
for the
sir.
transfusion
Yes.
all that. They every time they send the patient to us for medical management and the transfusion of the blood products and blood.
Yes.
And we can't offer the treatment further. And the thing is that we used to give the blood and everything. So this is the basic reason why we have kept the patient in the later lines. But still the data are there which they are suggesting us to use in first line. The results are wonderful, and maybe in the second line. The thing is why we, our patient are getting more side effect and western patient are not getting much side effect is the generation of the lutetium. Because the German or the exported material, they have the very less free drug lutetium. And in our setting, the indigenous lutetium, they have the high amount of the free lutetium, which affect the marrow badly. I guess this is the reason.
Yes, sir.
And the imported one is very costly, so they are not going for 4.5 lakh therapy per cycle and all that. Yeah. So I will touch Dr. Neha has not joined, I guess, and Dr. Manoj. So one concluding remark from the Dr. Mukesh, sorry, not Manoj, Dr. Mukesh. So suppose this patient want to take further treatment with you in Hisar, and where lutetium therapy is not available, we have exhausted docetaxel, abiraterone, and PrAP inhibitor also, olaparib. So anything which you want to do, which can guide the treatment, Dr. Mukesh.
Yes, sir.
We
Sir.
exhausted 3 lines.
And disease is confined to bone only, sir?
Yes. Bone. PSA is increasing. That is fine.
Yes, sir.
PSA is increasing, but disease is confined to bone.
Okay. And
You might
radiation-
ask the PSMA PET at this juncture, because patient has sharply rising PSA and all that. So even if the symptoms are confined to the bone, they might have some visceral disease. So we have done the PSMA PET again. And well, this such patient is showing one nodule in the duodenal area. This was a real patient, so I'm asking. So one of my patient had this some nodular uptake in the duodenum.
Okay.
So PSA rise was sharp, but still he had something in the duodenum. So we did the endoscopy and endoscopy guided biopsy, and suddenly it showed like it is a neuroendocrine tumor transformation. So how you will proceed further?
Sir, we should proceed with, if it is neuroendocrine, then proceed with simple PET scan, because it may add more information for the disease, and then we can address this patient with taxane plus platinum combination.
I didn't hear you actually. What you were saying? In metastatic setting, neuroendocrine tumor transformation. Then what you will do?
Sir, if it is tumor transformation to neuroendocrine differentiation, then we will proceed with the taxane plus platinum combination.
Okay. Right. You might give etoposide also.
Yes, sir. Etoposide also is an option
Okay.
with platinum.
Yeah, platinum, cisplatin. Right. Okay. So Dr. Neha is asking. Dr. Neha, I guess she has joined something somewhere. So do you shift from antagonist to agonist in real life in clinical practice in the castration level, if castration level is achieved? Suppose we have started the patient today with the Degarelix, right? And patient has completed all the treatment with EBRT and all that. Now in the adjuvant setting, would you like to switch over to LHRH agonist, that is leuprolide and all that? Mukesh, would you like to go for 3 monthly therapy?
Yes, sir.
Yeah, so it is a
Totally.
common practice. It has two reasons why we need to shift over there. Because Degarelix, there is a concept of antibody generation against the Degarelix part. So there will be IgG antibody generation against this after year and so. So we might change the thing to the leuprolide, and this may improve the results. And in the you can adjuvant setting, giving treatment at 3 monthly interval is a good idea. Patient need to come every month. So this is the good thing. So for with this remarks and all that, we are exceeding the time limit. So I would like to conclude here, and I would like to thank our esteemed panelist, Dr. Surendra Beniwal. He has joined but lost the connection. Dr. Umesh Khandelwal, Dr. Prashant Kumbhaj, Dr. Ananya Parikh, Dr. Anuraj Purohit. Neha, I guess she couldn't join, and Dr. Mukesh. So thank you very much. If you have any question, you can ask the audience and me. And if no, then we will conclude and over to the Samarth team
Thank you,
if
sir.
you want to speak over. Yeah. Thank you.
Thank you, sir.
Thank you, sir.
Thank you so much.
Thank you,
Thank you
Mukesh.
so much, sir. It was a wonderful discussion on prostate cancer. So now I would like to call Mr. Saurav Shah for the concluding remarks.
Yeah. Thank you very much to all our respected panel members, and special thanks to Dr. Asim sir for such a nice tips and fantastic discussions, which is very scientific. And I definitely sure ki the attendees or the delegates who is joined this meeting, it is another thing that is 180 attendees has joined this webinar now in the platform. Yeah, so from different state, from different corner of India, they have joined. Probably the meeting could be some more longer. So we will be organizing the next meeting with one or two another case studies. And with that, I really happy to close this meeting with this. And I thanks to all the panel members for their time they have given to this meeting today. Thank you very much.
Thank you.
Uh, excuse me, sir. I have
Yeah.
one patient, Asim sir.
Yes.
Sure. Please
I
continue.
have one patient, very young patient of 38 year approximately.
Right.
CA prostate and biopsy is showing neuroendocrine differentiation.
Upfront.
Yes, sir. He received, now he is on third line therapy with the capecitabine and temozolomide.
Right.
He
Right.
progressed on dosicarbo, etopocarbo, and all that. BRCA test, I advise him for BRCA testing. His result is awaited now.
Okay.
Yes. Now he is doing okay, fine,
Right. Right. Right.
but extensive metastatic disease.
Yes. Yes. Neuroendocrine tumors are like that only.
Yes,
And if
yes,
you exhaust with the options, then you
yes.
might proceed for the DOTA therapy if it's sensitive to DOTA.
Okay, sir.
Yes. Yes. Yes.
Thank you,
Okay.
sir.
Thank you, Mukesh. Thank you
Thank you
very
very much.
much.
Oh.
Thank you, sir.
Thank you, sir. Thank you so much, everyone.